Well, I guess we'll use that little recording notice as my cue to get started. Thank you everyone for joining us today. As you are aware, this is one of our many master's essay presentations. This is the culmination of a semester and in some cases a year's worth of research or even more among our students. So we're really excited to be showcasing 4 students' work today. My name is Farah Qureshi. I'm an assistant professor in PopFam, and I'm just going to go ahead and launch us right in. So we will be starting with Amy Ozinsky. Amy is a women's sexual and reproductive health student or with that area of concentration, and will be presenting on the timing of pregnancy recognition, a scoping review. So Amy, do you want to take it away?
Thanks, Farah. All right. Yes, so I'm going to be talking about a scoping review of pregnancy recognition timing in the US. To start, it matters when people are first coming to know that they're pregnant because time is an important aspect of being able to make decisions and access care related to pregnancy. Later recognition can make it more challenging to access abortion care, which is more difficult at later gestational ages, especially in light of increasingly early gestational age bans on abortion in the US. And for pregnancies continuing towards birth, early recognition of pregnancy enables entry into prenatal care in the first trimester as recommended, as well as adoption of pregnancy promoting behaviors, while later recognition may increase the duration of adverse exposures in utero. So a little bit about what we already know about when people recognize pregnancy. It's possible that people are recognizing they're pregnant at different gestational durations from implantation through delivery, with various factors shaping that recognition at different points in pregnancy. Yet recognition is an often overlooked aspect of pregnancy experiences, and research on pregnancy often starts at the point of an already recognized pregnancy or assesses time to pregnancy among those trying to conceive, while little is known about how and when people first come to recognize they're pregnant. And pregnancy recognition is as well often treated as an instantaneous switch between kind of binary states of not pregnant and pregnant. However, for individuals, the process of coming to know that they're pregnant may involve several steps, which may not be linear in speed or direction. And there's no systematic synthesis of the available evidence on pregnancy recognition in the US and the factors influencing that timing. So the scoping review seeks to address this gap by summarizing what is known in the literature about this topic. For the methods, a scoping review is conducted according to the Joanna Briggs Institute methodology and the PRISMA scoping review guidelines. As no single term exists for what I'm referring to as pregnancy recognition, the search strategy included a variety of terms like suspicion, awareness, discovery, detection, testing, confirmation. And these terms were used to search 3 databases to identify empirical articles reporting on timing of pregnancy recognition in the US, restricting to literature published from 2000 onwards to reflect present-day experiences. And then Covidence was used for review management, and R was used to visually display the results. So for the results, the search yielded 2,093 articles, of which a total of 30 were included. The left shows the PRISMA flowchart for that full process, and then on the right, we can see the samples that the included articles were conducted among. Here is a word cloud showing the 12 different terms that were used to refer to the experience of what I'm calling pregnancy recognition in the included literature, which might be referring to distinct aspects of within the process of coming to understand one's pregnancy status, but only 4 studies specified between timing at different steps, such as suspicion followed by testing or confirmation, and then acceptance. So across the included articles, the overall average timing of recognizing pregnancy ranged from 4 to 10.5 weeks, most often occurring sometime in the 5th week. In addition to those overall mean timing estimates, there were 15 studies that dichotomized recognition at a certain gestational age to examine prevalence by that time in pregnancy. And 10 of these studies referred to this time as the distinction between early and what was considered late recognition, but these timings varied, as you can see, where the x-axis of this plot is indicating when in pregnancy that measure was set. And what I take away from these estimates is that somewhere in the 70% of people are recognizing pregnancy around 6 weeks, but approximately a quarter of people are recognizing pregnancy at durations beyond 6 weeks. Now, to talk about some of the factors that are associated with pregnancy recognition timing, first of which is related to pregnancy decision-making. Several studies observed increasingly later recognition between pregnancies that were intended, ambivalent, mistimed, and unwanted. And access to and trust in home pregnancy tests was found to facilitate earlier recognition than those seeking confirmation in clinical settings. And then among the studies of those seeking abortion care, it was consistently reported that those having abortions later in pregnancy took longer to recognize their pregnancies and were more likely to report recognition as a factor contributing to delay. And then in terms of the reproductive factors, the findings on the association between parity and pregnancy recognition were very mixed. And for menstruation, a missed period was often reported as a key signal of pregnancy, but especially for those who commonly experienced irregular menstruation, a missed period was often not in and of itself enough to be a factor convincingly indicating pregnancy, and many people needed to experience other signs and symptoms to begin down that path of recognition. For sociodemographic factors, many studies found that non-Hispanic white participants, those at older ages, those with higher education, and married participants recognized pregnancy earlier than other race and ethnicities, younger participants, those with lower education, and other relationship statuses. And then socioeconomic status was assessed in the literature with very varying measures, but regardless of what was examined, those with the kind of higher measure were found to recognize earlier. And having insurance compared to being uninsured, and then having private insurance specifically were associated with earlier recognition. And for our last set of factors, the relationship between pregnancy recognition and both weight and substance use were again very mixed, and then smoking was associated with later recognition. So to summarize, in terms of average pregnancy recognition, it was most often reported in the 5th week. And while discovering one is pregnant is often treated as a very straightforward, instantaneous event, in reality, the literature reveals that this can be a very complex process that includes assessing risk, interpreting signs and symptoms, seeking confirmation, acceptance, disclosure, and then deciding to seek care, all of which can be tied to socio-demographic factors shaping these processes. There was also a lot of variation in how recognition was measured, and I spoke about the different terms that were used to refer to distinct aspects of recognition experiences, but few studies examined timing at the different steps in the process of recognizing pregnancy. Often time elapsed was reported by participants directly measuring from the last day of their last menstrual period. However, in many of the articles, it was unknown from when participants might be reporting that timing. And what was considered late recognition varied, starting as early as 5 weeks, but this dichotomization does not necessarily represent meaningful measures for pregnant people, especially when placed at such early times in pregnancy. In terms of limitations, the scoping review only focused on US experiences of pregnancy recognition and was limited to peer-reviewed empirical literature. Given that there was the varying terminology, the search may have missed relevant articles using additional terms that were not captured in the search strategy. Uncertainty around estimates of recognition timing were not consistently reported in the literature, and so I didn't include them in the scoping review. And then this review only focused on experiences of first pregnancy recognition. However, pregnancy recognition includes the recognition of the absence of pregnancy, as in the cases of pregnancy scares or the confirmation of termination success, as well as pregnancies can be intentionally not recognized, as in the use of menstrual regulation. Despite these limitations, greater understanding of this process is meaningful as it has implications for pregnancy decision-making and accessing timely care. The socio-demographic differences in pregnancy recognition that I spoke about especially may indicate how social structures and systemic inequities influence access to pregnancy-related care, as well as knowledge and stigma. Many of these same characteristics have been associated with later receipt of abortion services and prenatal care initiation due to difficulty overcoming barriers to care, as well as worse pregnancy outcomes. And whether for those who are wishing to pursue abortion or continue pregnancy towards birth, variation in the timing of recognition means that these barriers to accessing care don't affect all pregnant people in the same way, which exacerbates inequities in accessing reproductive health care and pregnancy outcomes. So on that uplifting note, I just want to say thank you to Suzanne for being my reader and to Lori Rossman at the Welch Library for assisting with the search strategy. And I'm happy to answer any questions.
Great. Thank you so much, Amy. That was a wonderful presentation and a tremendous amount of work. A lot of abstracts to screen and findings to sift through. So we'll open it up now for questions from the audience. Or comments. So I see Dana just put a question into the chat. I had a question about the sample selection / representativeness of the samples in your study. So can you speak more to that point about representative samples?
Sure. The research that I included really varied in terms of like how surveys were conducted, whether it was interviews, and then the size. And so there were samples that were nationally representative studies conducted, like the Turnaway study among abortion patients. There was also a lot of the literature on the live births samples was including params. So obviously those are very large studies, but there were also significantly smaller studies that were just conducted, for instance, at one clinic or prenatal care location of care. So there was a lot of variation, and I decided for the sake of the scoping review not to kind of evaluate methodological quality, but noting how much those studies varied.
Great, thank you. We have time for maybe one more question. We have a minute or two.
Hi, Amy. I just wanted to, first of all, excellent job. This was a great synthesis of what you found in the paper. Curious your thoughts on what literature you were seeing from outside of the US and how these results or factors might differ, or what you think the ways in which they might differ if you're not super familiar or didn't come across a lot of that literature.
Yeah, thank you. I think the literature from outside of the US, which I reviewed a little bit, indicated similar factors that shape these decisions, and also just the variation that people can recognize their pregnancies throughout. But obviously context can really influence the exact timing measures. And so potentially the kind of 5 weeks average that I was finding wouldn't be the same in other contexts. And I think access to care can really shape that. And then another piece that I didn't include in the presentation for sake of time, but was included in my master's essay, involved what's sometimes referred to as like unperceived pregnancy, or people that are recognizing at delivery or very much later in pregnancy. And that literature is very limited in the US, but has greater focus in especially European and Australian context. And so I think that can help inform maybe some of the US experiences.
Great, thanks.
Wonderful. Well, thank you so much, Amy, for sharing your work. This is a huge accomplishment. Now we will turn to our next presenter, who's Daisy Zapata, who is in the maternal, fetal, and perinatal health track. Daisy will be presenting on maternal care equity, developing a comprehensive support program for undocumented expectant mothers in Maryland. So Daisy.
Hey, can everybody see my screen perfectly? Yes. Well, good afternoon, everyone. As mentioned, my name is Daisy Zapata. Today I will be presenting my master's essay titled Maternal Care Equity, the Development of a Comprehensive Support Program for Undocumented Expectant Mothers in Maryland. For some background, maternal health disparities in the United States disproportionately affects vulnerable populations, especially immigrants. Maternal health is closely tied to infant health outcomes, making it a crucial area for interventions. Through my experience as an asylum seeker advocate, I work directly with 4 expecting mothers, all in the pathway to seeking asylum. Their experiences really highlighted how maternal health is not a one-size-fits-all situation. Each woman faced different circumstances, had different access to different resources, and encountered different challenges. The program I'm proposing is designed to provide referrals to a variety of services that are available to these mothers. However, it is important to understand that while these services exist and are available to them, barriers such as language, legal status, and transportation, for example, can often lead to prevention of these mothers to fully access the care that they need. Oops. There are several current policies and programs that provide support for undocumented expectant mothers and their children. First, the Access to Care Act will allow for undocumented immigrants to purchase health insurance coverage starting in 2026. While it hasn't taken into effect just yet, it represents an important shift towards expanding healthcare access. Second, in 2022, Maryland enacted a bill that extended Medicaid coverage to pregnant women and their infant children, regardless of their immigration status. This means that more expecting mothers now have the access to essential prenatal and postpartum care, which is critical for both maternal and infant health outcomes. Finally, the USDA's Supplemental Nutrition Program for Women, Infants, and Children, or better known as WIC, has been supporting this population for decades. Since it was piloted in 1972, WIC has aimed to improve the health and nutrition of pregnant women, infants, and young children, regardless of their immigration status. Together, these policies offer important pathways to improve health access, though we must note that there are still barriers and gaps. The proposed intervention is a comprehensive support program designed to meet both the medical and non-medical needs of undocumented expectant mothers. First, through referrals, participants will be connected to key services such as prenatal care, mental health support, legal assistance, and housing resources. This will be done through warm handoffs and ongoing follow-up support while building strong relationships with community-based organizations, local clinics, and other trusted partners. Second, case managers will assist mothers with benefits applications, helping them navigate programs like the Maryland Health Connection in order to apply for services such as Medicaid, WIC, and SNAP. This step is critical as many families are eligible for these programs but often don't complete applications due to language barriers, fear, or lack of information. Third, the program will offer educational workshops that are culturally tailored. Topics within these workshops will include parenting classes, traditional healing practices, and understanding of decision-making roles that can influence maternal and infant health outcomes. Lastly, during the initial enrollment phase, each participant will work with the case manager to create a personalized care plan. This plan will consider both their medical and non-medical needs, helping ensure that services are individualized but also holistic. Now that I've outlined the intervention, I would like to talk about some of our expected outcomes and impacts of this program. Through this case management program, we expect several key outcomes among the participants. First, we anticipate seeing higher rates of healthcare utilization, including timely access to prenatal and postpartum care. We also aim for improved birth outcomes as early and consistent care can significantly reduce risk for both the mother and the infant. In addition, we expect greater access to mental health services. We also hope to see an increase in enrollment in Medicaid and other supportive programs like WIC and SNAP. Another important goal is enhanced access to legal and housing resources, which are vital for the stability during and after the pregnancy. And finally, if successful, this program could inform broader public health policies that are aimed at reducing maternal mortality and adverse birth outcomes among the undocumented immigrant population. For recruitment, ideally, we'd like to plan 100 to enroll 100 undocumented pregnant mothers over a 6-month period. To be eligible, women must be pregnant at the time of recruitment and reside in either Baltimore City or Baltimore County. Recruitment will occur through nonprofit organizations that are already working with this immigrant population, and as well as through outreach efforts at community events where we can directly engage with potential participants. Additionally, a referral form will be posted on the program's website. This form will be available in English, Spanish, and French, reflecting the most commonly spoken immigrant languages in the state of Maryland. However, it is important to note that participants who speak other languages will be recruited and accommodated for wherever possible. This project is guided by 4 specific aims. Aim 1 is to evaluate the impact of the case management program by measuring increase in healthcare utilization among undocumented pregnant mothers in Maryland. Aim 2 is to assess the mental health outcomes of participants who receive mental health services through the program. Aim 3 focuses on measuring participants' engagement with physical health services, particularly prenatal care, and exploring how that correlates with birth and health outcomes. And finally, Aim 4 is to assess participants' levels of vulnerability over time, with the goal of improving their overall stability and safety throughout the program. This study will use a mixed methods approach to evaluate the 12-month case management program. On the quantitative side, quarterly needs assessment data will be collected. We'll track the number of successful referrals made to external organizations and the participants' linkage to care. We'll also conduct statistical analysis to measure legal, health, and social service outcomes over time. On the qualitative side, participants will complete follow-up satisfaction surveys, and a smaller group will participate in in-depth qualitative interviews to capture a more detailed experience, and also their feedback. Together, these methods will provide a fuller understanding of how the program impacts health access, mental health outcomes, and overall stability for undocumented pregnant women in Maryland. This program has several important strengths. First, it targets shared challenges across different vulnerable immigrant subpopulations, acknowledging both their common experiences, but also their unique needs. It also ensures culturally competent, respectful, and tailored care, which is essential for building trust within this community and improving health outcomes. The mixed method approach offers holistic insights by combining quantitative trends with personal experiences. Additionally, if longitudinal data collection is incorporated over time, there's potential to track long-term changes in maternal and infant health outcomes. However, at the same time, it is important to recognize that there are limitations. Selection bias may limit the generalizability of findings to the broader undocumented immigrant population. There's also a risk for recall bias or social desirability bias, especially when it comes to self-reported data. Mistrust, especially around immigration status, could impact participants' willingness to engage fully. Finally, language and literacy barriers, as well as resource availability, can influence both program delivery and evaluation outcomes. Despite these limitations, the potential benefits of this intervention are significant and outweigh the limitations, and it can meaningfully contribute to advancing maternal health equity. I would just like to take a moment to thank the many people who supported me throughout this project. First, my reader, Dr. Mary Catherine Augustine, and my mentors, Dr. Camille Alexander, Dr. Michelle Decker, and Salma Tayel, and all from the Population, Family, and Reproductive Health Department. I'm very grateful for all of the valuable guidance and expertise I was provided with. I also want to sincerely thank the staff and clients at Asylee Women Enterprise, whose experience and insights really helped shape this project in very meaningful ways. And finally, to my friends and family, thank you for your constant encouragement and support. And thank you all here today for your time and attention. I'm happy to take any questions that you might have.
Thank you so much, Daisy. That was incredible. A really important work, especially in the times that we're living through right now. I really appreciated hearing all of the amazing insights and plans you have for this proposed program. So I'm going to turn it over to the audience for any questions. Maybe Daisy, you can stop sharing your screen so we could see other folks in case there are any questions. And you can feel free to ask either with your mic on camera or in the chat. Well, I'm happy to start with a question. So obviously, I think the elephant in the room is this issue of mistrust, given everything that we've been seeing play out over the last few months. So I was hoping to hear a little bit more about your thoughts around that, ways to address that, or obviously it highlights an even greater need for a program like this. So I'd just like to hear a little bit more about that, maybe also speaking to some of the experiences that you had speaking with women and working with asylum seekers as well.
Yeah, so mistrust, I would say, especially in my experience, when it comes to the intake phase, it's very prevalent even in the screening phase. There's a lot of questions, especially working with a nonprofit organization. Some of the funding is federal, so it can be a bit confusing. But one thing that I emphasized was always ensuring to give more information, explain how our services are separate from the federal government, and how, yes, there are certain guidelines we had to follow, but just being very clear about what the program provides. And also when it comes to benefits applications, for example, depending on which immigration path a client is, or participant in this case, is deciding to take, depends whether or not it would take a charge in their case. So I think it's very important, one, to be educated and aware of what the policies are, the pathways are, and the different charges that could affect the clients, and then being very open about how this program could affect them, if so, and why not. So I would say definitely being well informed and providing more information and always leaving space for questions. One thing that I really admired that AWE does specifically is I think bi-weekly, they have tried to do know your rights workshops on different topics. For example, safety planning for families, or just updates on any policies that are changing. So I think it's very important to like reassure the clients that you're very inclined with what's going on politically, and making sure to inform them as well and leave the room for questions.
Great, thank you so much. That's really helpful. So I see we have time for maybe one more question quickly from Emmy, who said, not sure if you're working with clients in the last couple of months, but if you were, have you seen an increase in discomfort and distrust?
Yes, absolutely. At least when it comes to the screening process before we do any intakes, my supervisor has noted that it's been hard to get clients to come into the office to begin with, because the mistrust, the fear. And even in one of my most recent intakes, I am starting to see clients asking a lot more questions as to kind of like, why are you providing these resources? Why? It kind of seems too good to be true. And also I've noticed like some clients really hesitant, or like kind of reaching out to family members, asking them what questions should I ask in the middle of an intake. So there's definitely been an increase in discomfort and distrust and uncertainty of how a program like this can exist.
Thanks. In some ways it was a no-brainer question, but I was interested to hear the direct impacts on people's lives and concerns. Thank you, Daisy.
Thank you so much, Daisy. We will now turn to our third presenter, Yordanos Tesfai, who's going to be presenting on her paper, which focuses on cardiometabolic conditions of pregnancy among migrant birthing people, a scoping review. So continuing in the theme of focusing on immigrant populations, and Yordanos also is concentrating in the maternal, fetal, and perinatal health track. So Yordanos, do you want to take it away?
Yes, thank you. Okay, wonderful. Good afternoon, everyone. My name is Yordanos Tesfai, and today I'll be presenting the results of a scoping review regarding cardiometabolic conditions of pregnancy among migrant birthing people. Before we start, I would like to acknowledge the ancestral homelands where this research was conducted on by acknowledging the unceded territory of the Piscataway and Susquehannock people of Hopkins institutions where these institutions reside on. With that, I would like to provide a brief overview as cardiometabolic conditions of pregnancy are significant drivers of pregnancy-related morbidity and mortality globally. In specific, this review will focus on hypertensive disorders of pregnancy and gestational diabetes. Hypertensive disorders of pregnancy, or HTP, include preeclampsia, eclampsia, as well as chronic and gestational hypertension. These are a group of conditions characterized by high blood pressure during pregnancy, which can impact maternal and fetal outcomes. Gestational diabetes, or GDM, includes the development of high blood pressure or high blood sugar levels during pregnancy and requires management during and after pregnancy to avoid risk of complications. To date, global estimates state that 18.1 million pregnant women are affected by HTP, with recent research reporting a 10.9% increase in prevalence from 1990 to 2019. Additionally, 14% of the global population, or roughly 30 million pregnant women, are impacted by GDM. As there is compelling evidence that cardiometabolic conditions of pregnancy are unequally distributed across migrants, this scoping review was intentional in defining the target population. By definition, migrant birthing persons include the experiences of refugees, immigrants, and asylee seekers. However, it is important to note that all papers refer to migrant populations as either migrants or immigrants and do not explicitly name refugees or asylee seekers as part of their populations. Additionally, to contextualize the language researchers used, as most studies refer to non-migrant populations as quote-unquote native-born, we also want to acknowledge that this term can erase the history of indigenous populations. So, for consistency purposes, this presentation will group the target population as migrants in comparison to non-migrant groups. Next, we will now define the immigrant health paradox, as this will guide our approach to this review. The immigrant health paradox describes a phenomenon where immigrants exhibit better health outcomes compared to their non-migrant counterparts, despite the challenges of acculturation and limited financial capacity. First coined by Carnot and Edgerton in 1969, exploratory studies by Marquise and Corile, as well as Reed and Emerson, have investigated this phenomenon among Black and Latinx communities, which have led to consistent findings of better health outcomes in migrant groups compared to non-migrant groups. As a result, the purpose of this scoping review is to investigate the immigrant health paradox with respect to cardiometabolic conditions of pregnancy. Given this information, the hypothesis for this review is migrant birthing people will experience a lower prevalence of HTP and GDM compared to non-migrant groups across different geographical contexts. As for our methods, this scoping review was conducted in adherence to PRISMA guidelines, where search was conducted in both PubMed and Embase. Inclusion criteria included peer-reviewed full-text empirical articles published in English through January of this year. Additionally, other articles examined HTP or GDM among migrant birthing people and provided information on nativity or immigration status. Furthermore, each study reported health outcomes among a non-migrant reference group for comparison. Next, we'll discuss the results, but before discussing individual findings, I would like to provide a brief overview of the included studies. 15 studies were included, and among these, 8 explored HTP and 11 explored GDM. 60% of the studies were based solely in the US, and other countries represented included the UK, Australia, Chile, and France. Additionally, 2 studies conducted cross-country comparatives, with one study comparing Australia, Canada, and Denmark, and the other comparing Australia, Canada, Denmark, Sweden, Spain, and the US. To add on, 14 studies focused on first-generation migrants, and 2 studies provided information pertaining to the length of residency in the destination country. Furthermore, each study's population was limited to only migrant populations. It did not provide further information regarding the reasons for migration, displacement, or legal status. Data sources for each study included medical records to assess HGP or GDM diagnosis. Next, we'll transition to the results pertaining to HGP in the US. Araneta and colleagues reported most non-migrant populations experienced lower rates of gestational hypertension compared to the comparison group. However, Urbetta, Scott, and Singh all stated higher rates of hypertension or preeclampsia among US-born groups compared to their migrant counterparts. In specific, I wanted to highlight Singh and colleagues as this was a nationally representative sample of nearly 8 million people and provided maternal hypertension prevalence estimates comparing non-US born to US born groups. Large differences were seen among Black women, where the maternal hypertension prevalence among Black non-US born individuals was 7.1% compared to Black US born individuals at 10.3%. Next, we'll discuss the findings from studies outside of the US. Given the heterogeneity of these samples, findings were also mixed across geographical contexts. Dalen and colleagues reported lower rates of hypertension among migrant women compared to Australian-born non-migrant women. However, Esther and both papers by Yarkia reported lower hypertension or preeclampsia prevalence among non-migrant-born women. On the other hand, conclusions for GDM were much more consistent across studies. Across geographical regions, GDM was higher among migrants compared to non-migrants. GDM, or in addition to that, only one study conducted by Ortiz and colleagues in Santiago, Chile, reported Chile-born women experiencing higher rates of GDM compared to non-Chile-born women. However, it is important to note the smaller sample size, and as this was the only study based in South America, there may be other factors impacting researcher conclusions. For GDM, 2 large cohort studies that I want to spotlight are by Shah and Singh, where both concluded that higher rates of GDM were present among migrant women. Shah and colleagues concluded that higher rates of GDM were seen in women born in India compared to non-US born and US born overall rates. Similarly, Singh and colleagues reported that women born in India, the Philippines, or Vietnam had higher prevalence of GDM compared to their US born Black and non-Hispanic white counterparts. Overall, given these conclusions, GDM was noted to be higher among migrant groups, which is not consistent with our hypothesis. Across countries, the conclusion was supported except for the one study that was based in Chile. However, the presence of the immigrant health paradox was more present in HGP outcomes, especially in non-US based studies. Facilitators of this paradox can include stress pathways such as acculturation, migration trauma, and lack of access to chronic disease management, leading to differences seen among migrant groups. At the same time, this review is not without limitations, as there are differences across regional settings. Considerations for generalizability are warranted. Additionally, as there was no consistent reporting of migration data or nativity status, this can introduce study bias and incorrectly estimate prevalence or risk for migrants. Also, as there was limited data disaggregation across geographical regions coupled with missing data among migrants with increased vulnerability, such as refugees or asylee seekers, quality and availability of data are other limitations to consider. With that, this review does provide novelty to migrant research. It explores migrant health disparities across global contexts and uses reliable data sources such as medical records. Lastly, as most studies based in the United States were conducted in immigrant populous states such as California and New York, this can provide a focused understanding of cardiometabolic conditions of pregnancy among migrants in this community. To wrap up, recommendations for future research include exploring differences and disparities among more vulnerable migrant groups, such as refugees and asylee seekers. Also, increased global representation of migrant groups in research outside of the US can increase generalizability of findings. Lastly, future recommendations should also address misclassification and nuance to the migrant experience to explore drivers of differences in outcomes as opposed to comparing broad differences across groups. With that, I would like to acknowledge my faculty reader, Dr. Farah Qureshi, for your insightful feedback throughout this process, as well as Dr. Jeffers for your ongoing mentorship. And lastly, thank you to my parents, family, friends, and community for inspiring this work and for your unwavering support. With that, these are my references, and thank you everyone for your time and for listening.
Thank you so much, Yordanos. It's so wonderful to see this all come together. It's been a pleasure working with you, and this is just a great presentation. So I'm going to turn it over to, again, our audience, see if anybody has any questions.
I do, but I want to wait to see if any students have questions first, so I'll be quiet.
Trying to prioritize our student attendees.
They're all telling you what a wonderful job
I
you
know.
did, Yordanos. They're busy. All right, I'll go ahead. I completely agree with your conclusion about needing more research to sort out sort of, especially in the US, the disparate relationships you found with migrant status and cardiovascular diseases. Do you have any sort of thoughts about why we might see differences among immigrant groups by destination, or for these inconsistencies? Just speculating, or given what you've seen in the literature?
Absolutely. I think something that kind of ties back to the need for more research is the lack of data available for other migration paths. So obviously we saw a majority of studies that were based in the United States, but something that was really shocking to me was the lack of available data concerning the Mediterranean route, so specifically North Africa to Italy, as well as Germany. And we know that these are high migrant populous communities and countries. So I think that could probably play into the fact that there isn't as much research coupled with just the availability and access of migrant research overall. And going back to the lack of data on like specifically migrants who may be more vulnerable to cardiometabolic conditions of pregnancy.
Thank you.
Any other questions? I have one as well, but I'm gonna, since Yordanos has been talking to me nonstop for the past 4 months, I want to open it up for someone else. Well, it seems quiet, so maybe I'll ask my question. So Yordanos, I know we talked a little bit about, you know, the implications of what your finding was with respect to GDM, and why we would see that actually migrant birthing people might have higher rates of GDM. It's pretty remarkable that across these very diverse geographic contexts, we're seeing these consistent results. So could you, again, speculating as to why you think that might be the case, share some of your thoughts in terms of how you interpreted that?
Of course. So there has been some research linking increased GDM that was higher in migrants due to diet, but that was specifically in regards to migrants who have been here for a longer amount of time. At the same time, though, I didn't think that it was appropriate to include diet as a factor since majority of the studies did not reference length of residency in their respective destination country. But I think that could be a possible factor. In addition, I think going back to other lifestyle factors may be possible contributors to the GDM that we see that's higher among migrants compared to non-migrants. But again, because it was a bit more variable, I think that more research would be needed to consistently generalize these study findings.
Yeah, I totally agree. I think there's also, it kind of relates back to your answer to Emmy's question, which is like, if we're taking into account where folks tend to be migrating from, and if we're thinking, if we know that, you know, some of these lifestyle factors are the primary drivers of GDM, then you start to think about, well, how is like the targeting of the food industry in certain populations in the world? We know that like Nestle and other industries are starting to target low and middle income countries more, and that tends to be where migrant populations are immigrating from. So there could also be some kind of broader, you know, structural systemic forces that are influencing this and potentially challenging that immigrant health paradox as well.
Yeah.
So.
And the immigrant pathways, I mean,
yeah,
the length of journey, difficulty, so on.
Absolutely.
Also structural, so.
Thank you so much.
Great review.
Great. So we have one more presentation left. I will turn another one of my students. Happy to see you here. Emily Lin will be presenting on neighborhood level factors and cardiometabolic health outcomes during and after pregnancy, a scoping review of maternal health research, and she is also in the maternal, fetal, and perinatal track. So Emily, I will turn it to you.
Thank you, Professor. Hello, everyone. My name is Emily Lin. Thank you so much for being here today. I am excited to share findings from my master's essay, which is a scoping review that explores how neighborhood level factors may shape women's cardiometabolic health outcomes during and after pregnancy. So to start us off, let's talk about why this topic is important. Cardiometabolic complications in pregnancy, such as gestational diabetes mellitus or GDM, and hypertensive disorders of pregnancy or HDP, are not just short-term problems. These conditions can significantly increase a woman's risk for chronic diseases later in life, including type 2 diabetes, heart disease, and stroke. So previously, research has focused heavily on individual level risk factors such as age and BMI or medical history. However, we know from previous population health studies that the environments people live in also matter. So in this project, I examined how neighborhood level exposures such as pollution, socioeconomic deprivation, or access to healthy food might impact maternal cardiometabolic outcomes. Therefore, understanding the effects of these factors can be useful for future population-based interventions and reduce women's chronic disease risk. The research question guiding this review is, how do neighborhood level exposures impact women's cardiometabolic health outcomes during and after pregnancy in the United States? I hypothesized that adverse neighborhood exposures, for example, high levels of air pollution, neighborhood deprivation, or crime, would be associated with increased risk of GDM and HDP. On the other hand, positive environmental features like walkability or greater access to nutritious foods might help reduce those risks. Now let me walk you through how I conducted this review. I searched PubMed in November 2024 and included studies that were based in the United States that focus on either hypertensive or metabolic conditions during or after pregnancy, and that measured neighborhood exposures using geographic or spatial methods. I excluded studies that only assessed individual perceptions of neighborhood, were conducted outside of US, or focused on populations with pre-existing conditions. Using Covidence, I screened studies and extracted information on exposure types, outcome definitions, covariates, and analytic methods. In total, 21 studies met the inclusion criteria. So let's take a look at the types of neighborhood factors that were examined in the studies. I grouped them into 5 broad domains: socioeconomic conditions, environmental exposures, the social environment, neighborhood resources, and the built environment. These domains include indicators such as neighborhood deprivation, air pollution, crime rates, access to healthy or unhealthy food outlets, walkability, and access to fitness center. Some exposures like fast food density or pollution were classified as adverse, while others such as green space or access to fitness centers were considered protective. And although acculturation is typically treated as a psychosocial factor, one study measured it geospatially as a proxy for cultural context at the neighborhood level. So all the 21 studies were conducted in the United States. Most took place across multiple clinical sites, with 4 national studies, 6 conducted in the Northeast America, and 5 conducted in California. The majority were longitudinal in design, and sample sizes range from fewer than 500 participants to more than 300,000 samples. And finally, the studies were published between 2008 to 2024. So now I'll go into the findings, starting with gestational diabetes. The strongest and most consistent associations were observed between food environment exposures and GDM. Multiple studies reported that living in areas with more fast food outlets or fewer supermarkets was associated with increased GDM risk, although some findings varied by geographic location. Additionally, results mainly showed that environmental exposures, particularly PM2.5 and PM10, were also associated with GDM, with one study found that PM2.5 constituents like black carbon, nitrate, and organic matter increased risk, while sulfate showed a protective effect. Findings for socioeconomic conditions were generally consistent with the hypothesis. Greater neighborhood deprivation and economic hardship were linked to greater risk of GDM, but results varied when stratified by race and ethnicity. As for built and social environments, findings were more limited. While walkability was showed as a risk factor, access to fitness centers showed a protective effect, while two studies found that living in ethnic enclaves was linked to lower GDM risk. So now let's turn to hypertensive disorder of pregnancy. Findings in this area were more variable. Exposure to traffic-related pollution and VOCs were linked to elevated HDP risk, while exposures like NO2, CO, or ozone, and noise pollution were generally not associated. Evidence on socioeconomic and social environments was mixed. Two studies found that neighborhood crime rates was associated with increased HDP risk, while others found no results for SES and housing vacancy. Green space also showed inconsistent association across studies. So overall, there was less consistency in HDP-related findings compared to GDM. So only one study in the entire review examined outcomes after pregnancy. In that study, women living in high disadvantaged neighborhoods during pregnancy had a significantly higher risk of developing cardiovascular disease within 1 year postpartum. Now I'd like to summarize the main findings from this review. Adverse neighborhood level exposures, especially those related to food environment, were the most consistently linked to increased risk of GDM. This includes things like fast food density and low access to healthy foods. However, not all results were consistent. In fact, findings varied across different types of neighborhood domains, and evidence for HDP was both more limited and more mixed. Interestingly, most of the studies focused on adverse exposures, things like pollution, deprivation, or limited resources. Relatively few studies looked at positive environmental factors like access to green space, walkability, or community resources. Finally, variability in exposure measurement, timing, and study design made it difficult to draw clear, consistent conclusion across all studies. There are several important gaps and limitations to note. One major issue was that many studies didn't clearly define the timing of exposure, which makes it harder to understand causal pathways. Also, very few studies look beyond pregnancy to examine post-pregnancy exposures or long-term health outcomes. Because of the heterogeneity in exposures and outcomes, it will cause more difficulties to conduct a meta-analysis. And it also possible that some relevant studies were missed if they didn't use the term neighborhood in their keywords or indexing. That said, this review has some key strengths. By focusing on US-based studies, the findings are more directly applicable to domestic policy. This review also used a life course perspective and integrated a wide range of neighborhood level exposures. In conclusion, research on neighborhood conditions and maternal metabolic health is still limited and quite variable. While some patterns are emerging, especially for GDM, the overall evidence base remains sparse. In many studies, the pathways linking neighborhood exposures to health outcomes weren't clearly defined, which limits our understanding of how these relationships actually work. Also, future studies should try to take a life course perspective, clearly define exposure timing, and identify sensitive periods during pregnancy. It's also important to explore potential mechanisms like stress, access to care, or nutrition that might explain these associations. Lastly, we need more research on positive neighborhood features, not just the harmful ones. Thank you again for Dr. Farah for being my reader, and my parents and the PFRH faculty and staff, and all of you for your attention. I'm happy to take any questions. Thank you.
Thank you so much, Emily. I know that this was a labor of love. It was a lot of work that we started in the fall. So great job summarizing some pretty complicated and diverse findings. I will now open it up again to the audience for any questions. Cynthia.
So great job. As you were presenting, I was side chatting Emmy Hughes to say, who can argue with a life course perspective? So of course we love that recommendation, but really terrific work. I guess I had a question for you in thinking about maybe some of the larger studies that were looking at these neighborhood effects across the 5 domains. Did they simultaneously try to assess sort of individual factors or things that might be going on with the household that might contribute to the outcomes they were studying, or were they sort of solely looking at neighborhood factors?
So for the larger studies, they estimate like many of the variables, like maybe like green space and deprivation in the neighborhood, but not so much in like household level, and also for individual level.
Yeah, it's so unusual to have data sets that have been created that look at both individual level things and behaviors, and then also control or consider the independent effects of neighborhood factors. And I think there are several that are on your Zoom today that will be looking further in these areas. So thanks so much for sharing.
Thank you so much.
Thank you for that question, Cynthia. Any other questions or comments that other folks have? I'm happy to fill in one more question for the road, although again, as with Yordanos, Emily has been hearing from me nonstop since like September. But I guess my question is more about the process. So this was a really huge undertaking. So could you share a little bit with us about your experience kind of sifting through a lot, like first of all, conducting a search on such a wide variety of exposures, and then how was the process of kind of sifting through the results?
So yeah, it's like a huge database for me to like organize. So basically I just separate them into different domains, and then I see like connections between factors and outcomes by like sorry, can you repeat your questions again? Like you mean how do I organize?
How specifically, I guess I was just saying, just reflecting on the process, was it challenging? Was it unexpected? Did you see like how did it go for you?
Yeah, I think it's quite difficult because we use a relatively huge search term to search for our research database. And also I feel like the studies were difficult to organize because there are so many mixed and inconsistent findings. I think mainly because like green space can be defined, like for example, green space can be defined by like vegetation index or tree canopy cover. So like different kind of variables can define by different definitions. So I think that is really hard to like organize it into like a like to see a pattern for those kinds of studies. So yeah.
You did a great job, as I said, of going through a really diverse mix of studies. And I think one of the takeaways that you had really resonated with me, which is the idea of needing to specify causal mechanisms that are informing your research too. So a lot of these studies, sometimes it feels like people just dump some variables in a model and see if there's an association. And so being able to specify what you see informed by theory, taking into account timing and mechanisms is definitely an important takeaway. And as a fellow life course person with Cynthia and Emmy, I'm a big proponent of that. So thank you so much. Thank you to everyone. These were amazing presentations. We can just see how much time, effort, energy you put into it. And we're just thrilled to get to celebrate with you all as we approach the end of the year. We hope that everybody can stay tuned next week. I think we have our last round of presentations next Wednesday. But once again, if you want to give everyone a round of applause virtually or in person, and we will see you all next week.